Good morning and welcome to today's Oncology Data Advisor interview. Today I'm once again joined by one of our editorial board members, Dr. Stephen Freedland, who recently returned from the 2025 ESMO Congress in Berlin, where he presented results of the EMBARK trial. And today he's here to tell us some more about these results. Dr. Freedland, always great to have you on the show.
Kira, it's always great to be here.
Definitely looking forward to hearing more about the results of this trial today. So to start off, would you like to give us an overview of the EMBARK trial and what it investigated?
Yeah, so we've known for a long time that patients with biochemical recurrence, rising PSA after surgery or radiation, represent a heterogeneous patient population. But we have also known that those with a short PSA doubling time, where the PSA is rising very rapidly, are at high risk of developing metastatic disease and dying of their cancer. And we have seminal papers going back 30 years on this. And so the question has always been what to do for these patients. And that's where EMBARK steps in and says, well, traditionally, once we've done our surgery or radiation, we had to do salvage radiation, we have a second chance at cure. Once all that's failed, we typically do hormonal therapy, androgen deprivation therapy. And EMBARK basically said, I think we can do better. And let's test that. And so that's what it was. It's a randomized trial in this high risk, conventional imaging negative biochemical recurrence setting of ADT versus ADT plus enzalutamide versus enzalutamide by itself. And that was the trial. The primary outcome was development of metastasis or death, also known as metastasis-free survival. So that's kind of the background and setup of the trial.
Great to know. And I know we've talked on the show before about some of the prior results. So what was being investigated in this new analysis that you presented?
Yeah, so we'd previously shown that both enzalutamide plus ADT, as well as enzalutamide by itself, delayed metastasis or death, known as metastasis-free survival. That was the primary outcome, led to inclusion in the guidelines, FDA label expansion. But in oncology, the gold standard is always overall survival, right? It's a pretty early patient population, so it took us a long time to get to that. But that's ultimately the question is, does taking this regimen lead to better survival than what we've done historically? And that's why it was really exciting to present at ESMO in Berlin to show that the ADT plus enzalutamide had a highly statistically, but very impressive reduction in the risk of death by over 40%. Really, in a global phase 3 trial, based upon the hazard ratio, unprecedented survival advantage. The greatest survival advantage we have ever seen in a global phase 3 prostate cancer. When we looked at all patients, you could always cherry pick a small subset that does really, really well. But this was all the patients in the trial. Just really, really, really impressive. And hit many of the secondary outcomes, which we updated. And monotherapy, didn't quite reach statistically significant survival benefits. The hazard ratio is 0.83, so below 1, suggesting some sort of benefit, but not statistically significant for overall survival, but did hit many of the secondary outcomes that we were looking for.
It's great. It's so exciting that it was an unprecedented benefit. That's really exciting
Absolutely.
to hear about. Awesome. So now that we have these results, what does this tell us about enzalutamide, how to use it? How does it change how it's used in practice or confirm it?
Yeah, no, absolutely. So, I mean, in this setting, enzalutamide was already a category 2A recommendation. If you look at NCCN, it's already approved by FDA, EMA, many countries around the world. I'd love to think this moves to category 1 now for the combination with overall survival advantage, and really establishes it unequivocally as the standard of care. And monotherapy, I think, still has a role in a certain subset of patients. It better preserves sexual activity, hits many of its secondary outcomes. But, if you really want that OS benefit, it's combination. And I think, with data like this, it's just really hard to ignore, with really an unprecedented over 40% reduction in the risk of death, really, really just unprecedented benefits. And what it's telling us is a few things. And one is enzalutamide is a pretty good drug. We knew that, but I think these data just reaffirm that. I'm not here to say it's the best drug or anything, but I'm not trying to compare to any other drugs. I just think it's a really good drug. It has side effects. We need to be cautious of that. It's not for every patient, but in the right patient, if who can tolerate the side effects, really, really well. And so the next thing we need is for a good treatment is you got to pick the right patients. Because if you pick patients that are going to do well with the historical standard or aren't likely to progress or die of their cancer, they get no benefit and only are harmed by any treatment that we have. And so I think what it reaffirms is that a doubling time less than 9 months, these high risk biochemical recurrents really are high risk, that they are likely to progress and likely die of their disease and have tremendous benefits from an effective drug. And so the next question is, where are other places that we can improve upon the standard of care with enzalutamide or similar drugs? There are others out there. And then one of the patient populations where enzalutamide is not enough and we need to add something else on top of it. So there's a lot of directions as to where to go with the field, but it's a great day for our patients that we really can halt the natural history and really dramatically cut the risk of death from this disease.
Absolutely. That's fantastic to have these results that really reaffirm this. And
Yeah.
you mentioned the side effects and patient selection a little bit. Do you have any advice about either management of the toxicities that are associated or any advice for patient selection and deciding which patients would benefit the most?
Yeah, no, absolutely. Great question. So, I mean, the good thing is we're preserving quality of life. So we didn't negatively harm quality of life, but there are side effects, increased risk of falls, fatigue, hot flashes. To me, if you think about it, androgen deprivation therapy, ADT, has side effects, well-known side effects. And if you're a drug and you potently inhibit the androgen receptor, you're going to see even more of those side effects. If you don't see those side effects, I kind of wonder how well are you actually blocking the androgen receptor. It's not side effects per se, it's expected effects from blocking androgen receptor. But in real patients, we talk about managing the fatigue, making sure they're getting plenty of exercise, resting, eating well. Sometimes you have to dose reduce. Rarely you have to stop the drug. Often it's the ADT, not the enzalutamide. Seizures obviously is something we're worried about. We don't see often, but we do see about 1%. So again, that's the case where we'd certainly stop the drug. Beyond that, I think most of those side effects are relatively manageable. As you get to monotherapy, you do get a little bit of breast enlargement because you're not blocking testosterone or testosterone production. So testosterone actually goes up, gets aromatized to estrogen, can drive breast growth. So those patients we're going to either radiate the breasts and or low dose tamoxifen to try and block that estrogen and the breast growth. So I think the side effects are manageable in most patients. And, the nice thing is when we looked at it in terms of coming back to how well it works, at least for the combination, when we looked, we could not define any subset of patients within the EMBARK trial that did not benefit. Every single subset benefited as best we could determine. Interesting when looking at monotherapy, if your doubling time was less than 3 months, so the worst of the worst tumors, the hazard ratio relative to ADT, so we're comparing to an active control, it's not placebo, an active control, was hazard ratio 1.0. Absolutely no difference. But if you look at the doubling times 3 to 6 months, 6 to 9 months, those were kind of in the mid to high 0.7s. Still not statistically significant, but suggesting that if you really have the worst of the worst disease, you probably need the most aggressive treatment, which is combination. If you have a not as aggressive, still aggressive, but not as aggressive, that's where we start to put monotherapy on the table. And again, it's going to be side effects, quality of life, different decisions that are going to help drive what is done in practice.
Absolutely. That's great to know. And especially that the side effects are manageable.
Yeah, no, absolutely. And that's the thing. I mean, it's great we're preserving quality of life, but there are side effects. Every treatment has side effects. Very effective treatments tend to have more side effects because they're more potently inhibiting the molecular mechanisms that they're supposed to be. So, and enzalutamide's no different. There are some side effects that we need to be aware of and manage, but vast majority of patients are able to stay on the drug, get full dose, or at maybe a little bit of a reduction, and get those benefits that we saw in the trial.
Absolutely. It's great to know. You mentioned also a little bit about some of the unanswered questions and also like future directions. Do you have any analyses planned to investigate these new directions?
Yeah, so one of the things that we're very curious about, and not easy to look at when to go back and redo the trial, so to speak, but we had a treatment suspension. And if you got to 37 weeks, you had a great PSA response, treatment was stopped. And what we're looking at is how long did that treatment suspension last? And we've published that before, but it's among those who got treatment suspension, which is great if you're at that point and you're doing well, and I can give you some guidance as to how long you're likely to be off treatment. But when you first start treatment, you don't know if you're going to get treatment suspension or not. So we're kind of biasing things because almost everyone in the enzalutamide group got treatment suspension. On the ADT alone, a third of patients never got treatment suspension. So really, their treatment suspension is 0. So to quote, on average, it's 11 months. No, a third of patients got 0. So I think there's some interesting ways to look at it to really give a better message in terms of just, despite being able to be off treatment for X number of times, we still saw significant survival advantage. And likewise in monotherapy, the flip side is, I'd love to make it more effective. It bothers me that we didn't reach that overall survival benefit. I was certainly hopeful that we would. We saw trends, but I want to be true to the data. It's not statistically significant. And so maybe we shouldn't do treatment suspension at all in those patients. And obviously, you can't go back and redo the trial. There's some ways to look at the data and things that I think may support that argument, that maybe we should think about not doing suspension for monotherapy. Again, kind of going on a limb there. We talked about it a little bit in the discussion. We'd mentioned it was presented at ESMO, which is true. Almost simultaneously published in New England Journal of Medicine, which is great. So in the discussion there for the listeners, read the discussion and kind of some of our thoughts as to where we want to go with some of that. And hopefully those new analysis will kind of support some of that.
Absolutely. Yeah, we'll link to the publication here, and congrats on getting it published in there.
Yeah, absolutely. That's exciting.
Definitely. Awesome. So as I wrap up today, any other takeaways from your presentation or anything else you'd like to mention about EMBARK or, advice for practitioners using enzalutamide?
Yeah, I mean, it's just, the data are clear. Adding enzalutamide to our ADT once all local therapies have failed, really, really dramatic survival advantage, cannot be ignored. Side effects manageable for the most part, quality of life preserved, and you get treatment suspension. So you're not on this therapy for life. Maybe even we can do multiple treatment suspensions. We don't know. But really, really impressive data. Just cannot be ignored for the sake of our patients.
Absolutely. No, it's so exciting to hear about this data. So thank you so much, Dave, for coming on today to tell us about it. Look forward to hearing, future reports as well. And it's
Absolutely.
fantastic to hear this and share with the audience.
Absolutely. Thanks for having me.